Good evening, everybody. My name is Craig Norman, and I want to welcome you this evening to this Facebook Live event that is being put on by Euclid Systems Corporation, the maker of Euclid Emerald and Euclid Toric, and of course, the new product of Euclid Max and Max Toric as well. We really hope we're going to have an interesting discussion this evening with Dr. Barry Eiden, who's one of the preeminent clinicians that I know of. Barry's always a guy I look up to on what's going on with the latest and the greatest. Besides being a world-renowned speaker, educator, and also really well tuned into research into the contact lens field as well. Barry, I'm just going to read a couple of words about you for those that don't know anything about your background. Dr. Eiden is the President and Medical Director of North Suburban Vision Consultants, and is the assistant clinical professor at the University of Illinois at Chicago Department of Ophthalmology in the Cornea and Contact Lens Service. I already mentioned he has extensive experience in orthokeratology, which is what we're going to talk about with him tonight, but it's also in primary care and disease management and refractive surgery, and probably is the guy that I look to for keratoconus more than anything. That he has done quite a bit in that arena as well, including being the president of the International Keratoconus Association. Dr. Barry Eiden, welcome. How are you?
I'm great, Craig. Thanks for having me tonight.
Oh, it's great to have you here. I did want to mention just before you get started, and I'm not saying this just because it's you, but that the opinions and views of the speakers, which would be you and me, during the presentation are our own and have nothing to do with Euclid Systems.
100%.
Okay, so just make sure that we both keep that under consideration.
You got it.
So if you wouldn't mind, can you share with the viewers this evening a little bit of your journey along the Ortho-K path?
Sure.
You know, you were there basically in the beginning of modern Ortho-K. And can you just tell our viewers a little bit about that?
Sure, it'd be my pleasure. So way back when, before Ortho-K / corneal reshaping received FDA approval, to be very frank with you, in my optometric education, we were not really taught very much about Ortho-K. In fact, they dissuaded us in our education regarding orthokeratology. However, just before the approval of Paragon CRT, the folks who I knew and you know over at Paragon reached out to us and said, hey, you know, we have this new technology. It's going to get FDA approved very soon. We have a lot of interest in the media. We'd like you to get involved with us and help us out. And I said, sure, I don't know anything about it, but let's go ahead and do that. And they did a quick educational background for us. And they already had a piece with the WGN Superstation here in Chicago that goes all over the United States and I think across the world on this new approval of their new technology. So they wanted our practice to get some experience under our belts. So we started fitting some patients, had some good results. And guess what? We were interviewed. So we were interviewed by WGN, talking about the technology, had some patients interviewed, and well, the phone started going crazy. So all of a sudden, from a zero orthokeratology practice, we had a pretty active orthokeratology practice within a matter of a few months. Well, the interesting part was, as our experience continued, we started to realize that it was the control of myopia that was going to be the future of orthokeratology, in our opinion. And there were a number of practitioners in the greater Chicago area who were doing Ortho-K. And we decided, let's see if we can all get together, maybe co-market and that sort of thing. And we ended up meeting. We all agreed that myopia management was truly the future for Ortho-K and the only way it would really thrive. We were supposed to agree on cooperative marketing and doing things like that. Of course, we couldn't agree on anything. So that never turned into much in terms of that area. However, out of that was born a study that we did many, many years ago now called the SMART study. And Craig, you're very familiar with it. It was at that time one of the largest Ortho-K studies looking at control of myopia progression, comparing the Ortho-K lenses to daytime wear soft lenses. And that was my first introduction actually to Euclid, because Euclid volunteered to provide the Ortho-K lenses for us for the study. What was really interesting was their methodology of fitting patients, right? So all we had to do was provide Ks, corneal diameter, and manifest refraction, and they would design the lenses. And we had amazingly high success rates, even on first lens, well over 80%. Now, things have improved since then, so those numbers have gotten better. But that showed us, because we went from the Paragon system, which was a diagnostic lens fitting type system, to an empirical fitting system. And we realized we were equally, if not more successful in the empirical fitting system. And patients really reacted much better to that, especially with little kids, and you're not sure you're going to move forward. You put a rigid lens on their eye and their initial response isn't necessarily the most comfortable, right? So a lot of times the parents say, well, I don't want to fight with my kid. Well, when you're doing the empirical fitting, in essence, you're making a commitment before that first lens goes on the eye. And I can tell you the parents are much more motivated to encourage their kids to continue to get through those first few days and get comfortable with the lenses. So our dropout rate really started to go down as well.
Right.
And
so for sure that the SMART study was a landmark study at that time, right?
Right.
And I think about it in terms not just for what you studied, but it was basically made up of novice Ortho-K practitioners. Now, they were easy to find then because most people were novice Ortho-K fitters.
Undoubtedly.
And, you know, we're coming up on the 20th anniversary of that. That's kind of hard to believe that that's coming up now. But that really made a lot of sense for a lot of people to get their arms around a little bit more about the myopia management aspect of Ortho-K, because at the time it was just typically for what we would call adults, right? Over 18 years old, and that it was done to rid oneself of glasses.
Correct. But we knew that the future of this, especially, this was the same time LASIK was in its heyday, right?
Yep.
And, you know, everybody thought, oh, this is going to be an alternative to LASIK. It's not a great alternative to LASIK. In some cases, it may be. But when people want a permanent surgical solution to their refractive error, that's what they want. They don't want to be putting on a contact lens, whether it's to go to bed or to wake up in the morning. So we realized that that wasn't the mainstay. That was a small percentage. It was a myopia management aspect. And the SMART study, although it did have limitations, really did show a significant difference in myopic progression between the Ortho-K and the daytime soft spherical lens wearers.
Yeah, definitely. I was kiddingly telling somebody the other day that myopia management or myopia control, what terminology you use here in the US, it's mostly myopia management, is now at the point where it's a 20-year overnight success. In that those of us that have had our sleeves rolled up for that last couple of decades have been seeing all of the changes coming. But now it really is making a lot of noise in the eye care field, as is myopia.
Yeah, I think your point is well taken. We've been doing it, as you said, for 20 years, and we started adding all the various other alternatives for myopia management to our armamentarium of that particular aspect of our practice. But still, in our practice, at least, Ortho-K still is by far the most frequently used technique for myopia management.
Yeah, excellent. So I want to talk about a couple of things tonight. And if we could, I'd like to start with, you know, what goes through your mind when you have a patient sitting in front of you and you are going to fit them. Let's talk first about a child, right? With an overnight Ortho-K lens. How do you go through the mental checklist of lens design, type of lens design, meaning spherical or toric, that whole kind of thing, and what other kind of differences there may be in your thinking process of that child versus an adult as you're ordering those first lenses?
So, there is sort of that checklist that you just mentioned or alluded to. And so the first thing I want to know is there refractive error within the realm of what we can do a good job? Now, I realize a lot of people really go to the extremes in Ortho-K and try to fit much higher degrees of refractive error, higher degrees of astigmatism, even other things that really stretch the limitations of the technology. But I'd use the analogy of RK, right? If RK was limited to doing a 4-incision RK without going out to the limbus and dealing with 3 diopters of myopia, maybe it wouldn't have the bad rap that it has today. But of course, surgeons said, well, if 4 works, 8 must be good. If 8's good, 16 must be good, and so on and so forth. And that's why yesterday, my last patient of the day, who was I think it was a 9 or 10 diopter myope and had RK done, is now a 6.5 diopter hyperope with astigmatism. So the point being that when you start stretching the extremes of a technology, your success rate is going to go down. So there are plenty enough myopes within the realm of what's even FDA approved. And even within the FDA approved limitations, we like to bring it down a little bit. So I really don't like to try to go to the extremes. Sometimes I do if I have a highly motivated patient, but I'll tell them that our success rates aren't quite as high. So I try to keep our myopes at, under 5 diopters. I do care very much about both refractive and corneal astigmatism. That's very, very important because if we find that the refractive astigmatism does not match up with the corneal astigmatism, and we have internal or lenticular astigmatism, there's going to be residual problems in many cases. We don't want to push that envelope. There are other alternatives. When we talk about lens design, so to speak, that's all about topography. So when we look at topography, we look at a number of factors. What is the general curvature values of that cornea? Are they excessively flat or excessively steep? Those can be more problematic. We like them to be kind of in the heart of the artichoke, surely above 40 diopters and below 46 to 47 diopters. What's the eccentricity of the cornea? We look at that. If you have moderate to a little bit higher positive eccentricity, which is, the prolate shape of the cornea, those are going to respond better than the less common oblate corneas. Of course, we look at the astigmatism on the cornea. Is there significant astigmatism? And if there is it just central or is it going out limbus to limbus? As you know, if you go out to the limbus to limbus type of form of corneal astigmatism, if you don't use toric peripheral designs, you're going to have greater trouble centering those lenses and getting the appropriate treatment. So we consider that along the way as well.
Okay. I mean, that really covers everything there. But before we move on to talk a little bit more about the design and materials, when you compare for adults, are you doing anything different within the different zones with an adult versus a child, or are they very similar?
So, if we're thinking myopia management, in my mind, I want to get enough peripheral, mid-peripheral plus in the system. So I look at pupil size, that's very, very important, and then consider treatment zone size. Sometimes we have to go smaller to get that plus within the pupil, and how much of a relative peripheral plus effect or myopic defocus am I going to be able to generate in a standard design versus an enhanced myopia management design where you want to create more plus in that mid-periphery. So we do think about that for myopia management, i.e. kids. With adults, I'm almost the opposite, right? I want to make sure I have a nice wide treatment zone because I don't want them to have night glare and all those kinds of visual issues. So I may use a larger treatment zone. I'm not that concerned with how much plus in the mid-periphery I have. In fact, I probably want less.
Yeah. It's always amazing to me that when you look at kids, even with their pupils the size of a quarter, that very rarely do they ever make any comment regarding glare and flare.
Right.
Versus with an adult, anything close to that, they're complaining about the visual complaints that are occurring all the time.
You are correct.
I would like to step in for a second and just say for our viewers, if you do have any questions directly that you would like us to share with Dr. Eiden, please chat them into the chat box and we will pass those along. So Dr. Eiden, you talked about the designs a little bit. And can you tell me what your strategy is for choosing, for instance, a spherical design versus a toric design? And what are those key elements that cause you to say, okay, I'm going to switch directions here with the design choice?
Yeah, typically, our default is a spherical design. We've been utilizing them for years and years with really great success. So go back to the SMART study. In fitting all these kids, we didn't think about toric designs. Guess what? They didn't exist back then, right? Yet we had amazing success. We tried to limit the the astigmatism as indicated by FDA approval, or approval for Ortho-K, meaning that we wanted there to be less than a diopter and a half of with the rule and less than a diopter against the rule. Those were considered, but we didn't look so much at toric patterns on topography as we do today. So today things are different. Again, if we see that the astigmatism goes out to the periphery, more limbus to limbus, then we look at how much difference in elevation there is. Typically, if you're dealing with more than about 30 microns of difference when you average the two primary meridians, and typically it's suggested to use a core diameter of about 8 millimeters. And then you'll average along the flat meridian, you'll average along the steep meridian. If there's a 30 micron difference or more, you're going to start thinking about toric designs. And depending upon how much difference, some toric designs, greater amount of toricity in the periphery than others. And what that does, of course, it helps the lenses center better. It allows the treatment to be applied. And I think that's an important point that especially people who are new to Ortho-K need to understand, because we're always thinking of steep and flat fits related to base curve, right, in GP lenses. But it's not that way in Ortho-K lenses. The central base curve is used for vision correction, right? The application of sagittal depth of the lenses is controlled by the reverse curves and the alignment curves. And so what you basically want to do is to be able to either elevate or lower the lens to apply the appropriate treatment. You don't use the base curve for fitting purposes. So that's an important point I'd like to share with the audience for those who maybe have a little less experience in this area.
Yeah. Today, I think that those philosophies are easier to grasp for the new Ortho-K fitter if they've been exposed to like scleral lenses in optometry school, where it's all about moving the lens up and down through sagittal depth changes, which is exactly what we're attempting to do within Ortho-K.
I agree.
So that covers the designs very nicely. And I think, well, I will just make a comment. I'm amazed, by the way, how much the uptake has been over the past 2 to 3 years of toric lenses and how often they are actually used, because I agree with you completely that we didn't think we needed them for the longest time, right, because the results were doing very, very well as it is. But the more that we understand the science of Ortho-K, of course, more accurately fitting that peripheral portion of the cornea to give that position control makes quite a bit of sense.
Well, I'm going to tell you, in our clinic, I learned so much about what was going on with the application of Ortho-K after introducing aberrometry as a routine technique that we use, because sometimes visual acuity doesn't tell you everything. In fact, a lot of times visual acuity doesn't tell you everything. And I can tell you that when we run aberrometry, and we do integrated aberrometry on virtually all of these patients, and we see the high order aberrations that are induced when you have decentration versus a well-centered lens, the quality of the vision, even if acuity is the same, is dramatically different.
Yeah. Excellent point. It's also becoming kind of interesting today that from the myopia control, the myopia management category, there's a lot of debate now, in particular in the academic arena, of where that treatment zone should actually be to slow down the progression of the eye and therefore slowing down the progression of myopia. Either way, I think you'd like to have a lens that's centered, though, to be able to control that still as much as possible.
No doubt.
So that takes care of the designs, takes care of the topography. And of course, that's your right-hand tool, I'm sure, as you're following the patient from one visit to another and 1 year to another. When you are choosing a patient that is, let's say, a child in this case, what about lens materials? You know, today we have seen the entry of new higher decay materials, for instance, to go along with the mainstays that have been used for the last 20 years. What's that decision-making process like for you?
Well, I think it's a process in flux at this point, to be very honest with you, because of the new introduction of materials. When I think about contact lens materials, there was the kind of old traditional way we were taught in optometry school, which I don't think applies anymore, because higher oxygen transmissible materials were less stable, they didn't wet as well. All of the things that we didn't like, we only reserved them for those cases that absolutely needed to have high oxygen. Today, that's just not the case. The materials today are equally stable, have equal wettability, and also deposit resistance. All of the critical elements about material science, you don't have to give it up to get more oxygen. So I think we're starting to see that shift towards, why wouldn't you want to have more oxygen when everything else is the same? There's just no reason not to.
Yeah, totally agree. I mean, take a look at the soft lens portion of the practice, where we've migrated to maximizing the amount of oxygen in a single-use daily disposable,
right?
And worried about, would we lose some of the properties there as well? But that's been modified the longer that they've been in development, for sure. So to your point, so we have materials today that are, north of, 180, some decay materials that are, coming into the market, maybe at 200. But when we look at this higher decay of around 180 or so, to your point, what you're saying is that the fluctuations in the shape of the lens, the flexure, right, is not happening. I agree completely. The materials seem to wet well, which was also a concern as well before. And so there doesn't really seem to be a difference not to maximize that use. And so, and I like this thing that you are talking about. I like to refer to it as this balance of properties, right? So you have decay here, and you have wetting, you got stability, you've got handling characteristics, you've got durability. All of those together have to be working in a contact lens material, frankly, for any contact lens material, for it to be doing its job. And I think that we're seeing that in the higher decay materials today.
No doubt. I mean, I think this whole concept of biocompatibility on all these levels, that's what it really is critically important, but we don't have to sacrifice. We don't have to, there's no give and take anymore the way there used to be, 15 years ago. We did have to consider that. So those old ways of thinking really need to be thrown out the window at this point in time. And so again, I mean, if intuitively, why wouldn't you want more oxygen if you're not sacrificing anything else?
Correct.
Doesn't even make sense.
Well, closed eye environment, right?
Right.
Non-moving lens.
Exactly.
I mean, all of that just yells out, let's maximize the oxygen as much as we possibly can.
100%.
So, and by the way, I did hear a lecture recently where it was talking about those older material characteristics are the view of what we thought high decay was. And I was thinking the same thing, that this is baloney today.
Right.
That's not the way that we should be viewing these materials
Not at all.
as well. So how about management of the patients? So we've talked about the fitting, we've talked about the material choices, and I guess you're very clear there that you lean in one particular direction. with the lens materials with high decay and the balance of properties. What about the management of the patient thereafter? Do you have any tips for managing the child and their parent, of course, on the ongoing care of their overnight Ortho-K lenses?
Yeah, and we start this literally at the beginning, and you set the stage very, very early. I believe in, under promising and over delivering. So I kind of bring out some of the issues that they will face and to expect. And I use very simple language with kids. So for example, when we decide to move forward with Ortho-K and I have a parent in the room and the kids in the chair, I say, I just want you to know something very important. When you first get these lenses, and for the first number of days, maybe even up to a week or two, when you put these lenses on, they're going to feel annoying. And that's the word I use because my kids have always used the word annoying.
Yeah.
Normally it's dad, you're so annoying.
Yeah.
But I say to them, these lenses will feel annoying, especially when you have your eyes open and you're blinking. Now, if you close your eyes, like you're going to do when you go to sleep, you virtually will not feel them. And after X number of days, maybe a week or so, your eyes get used to it and it's not going to be a big deal. But you have to expect it's going to be annoying for that first week.
Yeah.
So therefore, I want you to put the lenses on just before you're going to close your eyes. Later on, when you get used to them, you can put them on an hour or so before you go to sleep and you can read because you can see through them perfectly well. So we talk about that. That's really important. That has reduced our rejection rate or dropout rate due to comfort by immeasurable numbers. I mean, I can't even think of the last time a kid dropped out due to discomfort because it was realistic expectations set. And in fact, I had a kid just last week. We were talking about myopia management. And I was talking about that. And he was like 9 years old or 10 years old. And he said to his dad, no, I don't want to do that. I don't want it to feel annoying. I'm not going to wear them. I don't want contacts, So he ended up using atropine and eyeglasses. So that works out fine too. But at least we avoided the issue of going through the whole process, having him drop out, having to talk about the big R word, the refund word. And I think that's important. Also, as you were alluding to, in terms of appropriate care, I explained to the kid, because it is a kid, that this is ultimately your responsibility. Mom and dad may help you, but you have to take the responsibility because now that we're putting a lens on your eye, you're talking about something that could cause a problem if you didn't take care of your lenses. If they're dirty and they get debris on them, then your chances of getting an infection or an irritation are higher. You don't have to worry about that if you take really good care of your lenses, then it's not hard. So again, start from the beginning, preventative kind of that sort of approach I think is proactively is very important.
Excellent. Hey, we have a couple of questions that have come through. The first one is that, although you've been talking about empirical fitting, as kind of the method of choice most often for you. Do you ever use diagnostic fitting techniques? And if so, when and why?
I'm going to be honest with you. I haven't done a diagnostic fit of Ortho-K for probably 16 years. So, even now when I'm using other manufacturers, some of which are quote unquote diagnostically based, I still do it empirically. There are empirical methods for even the diagnostic lens designs that are out there. I find from a practice management point of view, it saves time because the efficacy of empirical fitting is so darn high. And now with the advent of computer programs that are being developed to virtually fit these lenses based on topographic data, I don't see a major advantage or any role for it, and surely not in my practice, no.
Interesting. It does take away the potential for a negative response of the annoying before you ever get started. Right? No
doubt. Hugely true.
Yeah. So what about aberrations, right? When we're reshaping the cornea, we're flattening the central portion of the cornea, it's never 100% uniform. We're inducing some kind of aberrations. When you run into that, how do you manage that?
Well, I think the optimal management at this point in time is centration. There's not much more you can do. So when I have a really perfectly centered or close to perfectly centered design applied to the cornea, you will still see spherical aberration. It's very common. Some of those values are not significant and not great. And because of the centration, it's kind of even all the way around. The more discentered the lens, you're starting to get coma-induced and trefoil. And, you know, especially as those kids get a little older, you get the teenagers. Now, since we've been doing it for such a long time, I've got lots of college-age kids who are, you know, doing corneal reshaping and Ortho-K. As they get older, as their visual demands get greater, they're more sensitive. They become more adult-like and less tolerant. So it becomes that much more critical to address appropriate fitting. And again, with the newer designs, utilization of toric peripheries, all those things that help us center the lens. And remember, there's lots of things to center a lens, not just toric peripheries.
Sure.
It's having the right relationship for the reverse zone and the alignment. Is it riding too high? Is it riding too low? Do we have to modify the diameter if it's laterally decentered? All of those things are critical. Not that complicated. I mean, if you think about it, it's all elevation based, right?
Yep.
It's all sagittal depth based.
Yep. Once again,
Yep.
whether you're using the reverse curve or the overall diameter or even possibly some alignment curve changes, you're still talking about moving the lens up and down to achieve the better kind of position control.
Absolutely 100% true.
Had a couple of other questions. One is, this is an interesting one always. So on, you deliver the lenses tonight, right, to a patient, young kid and the parent. Part of the question, number one, is do you see them back tomorrow? And number two, do they come in with or without their lenses on?
Such great questions. And actually, this has been posed to me in other environments and made me rethink. My traditional way has been we do a 24-hour follow-up after the first night. Now that school is starting up all over the place, it doesn't mean that the day that we dispense the lenses is the first night they wear them.
Correct.
We like to do first night on Friday. Why? Because there's no school on Saturday. And then by Monday, their vision's going to be good all day long. So we typically either try to do dispense and on Friday and have them back on Saturday, or we might dispense on a Wednesday or a Thursday, but tell them don't put the lens on until Friday night, come back in Saturday for that reason, unless the parents don't care about taking their kids out of school. But so that's what we do. And we have, after all these years, always the first morning, have them come first thing in the morning with the lenses on. To be very frank with you, I don't know if it's been that valuable one way or the other.
Yep.
But the one thing that's really cool is the wow factor of that 24-hour from a practice management standpoint, where we take the lenses, we look at the lenses, we'll put some fluorescein in. Okay, everything looks good. The eye looks good. We take the lenses off. And what I usually do then will show the line of their uncorrected acuity when they before they started.
Right.
And they read it like bada boom, right?
Exactly.
And then I start going down. Oh, the next one. Wow, that's good. Wow, that's good. Now, you know, they started off 2100 and I'm going 2070 is good. I'm laughing to myself, but to the parent, then you're going down, down, down. And eventually, if you're fortunate enough to have 2020 in the first morning, which happens in a ton of cases, you know, we'll say, this is, you know, this is the golden goose here.
Yeah.
You got it, you know. But
That's
then
right out of the playbook of the refractive surgeons, right?
I'm going to be on, you hit the nail right on the head there, Craig. I modeled every aspect of our corneal reshaping practice after our refractive surgery practice. The agreement forms, the information forms, how we do follow-up, the wording that we use, all of those sorts of things. Exactly the same. And also, of course, after the first day, we also tell them your vision is really great now, but you have to expect that towards the end of the day, for the first couple of days, it's going to fade a little bit. Don't be surprised. You'll still see a ton better than you ever did before without contacts during the day or glasses. But by 2 days from now, you'll be seeing well all day long, unless something's not working well, you know, then we know right off the bat.
Sure. So to the best of your knowledge, what is the longest one of your patients has been under your care with Ortho-K?
Yeah. So for me, It has been now about 22 years, 21, 22 years. And I know there are practitioners who are doing it way before FDA approval, doing their own thing,
Right.
off-label, and they've been doing it longer. But to see people, and some of them as adults are continuing it on. They were kids then, but now they're obviously, like,
well, if they're 8, now they're in their late 20s or
right,
early 30s even, right?
Exactly. And now I've seen every combination. We've seen those who, once they reach that 20, 21 age, and maybe even going off to college, they see that Ortho-K just doesn't fit their lifestyle. That's absolutely fine. We go through the process of regression, we stabilize, and we move forward. And we have other alternatives if they are still progressing in myopia. The question in myopia management always is, how long do I have to do it? Right? So with Ortho-K, how long will my child have to do this? Well, I say to them, the statistics of myopia progression, typically 90% will stop progressing by the age of 20, 21, but there's still 10% who might go forward. But the bottom line is, at that point, you may not want to stop. And most of our patients don't if they're working well with it. They think it's wonderful. So they just continue on. And I say, at that point, we're not doing it for myopia management. We're doing it for daytime vision correction. So it changes kind of like the playbook there a little bit.
Yeah. I mean, that is amazing. And that, who would have predicted that, of course, when you fit these kids, that it would be that long.
Yeah.
And it's much easier to put in perspective looking backwards. Right?
Yep.
So the last question that I have for you before we wrap up here is if you had your choice of coming up with a new Ortho-K product or design, is there something that you think, of course, I know that you won't give away any intellectual property. I don't mean it that way by any means, but in theory, is there something that overall the industry is missing that could make the fitting or follow-up or results of overnight orthokeratology better?
Well, I think for me, there's a lot of different roads to go down based on that question. But the one to me that's relatively low-hanging fruit that I think needs to be addressed and then FDA approved, and I'd like to talk about that for a second if we can, is residual refractive astigmatism. And so when we're talking about toric designs, we're talking about toric peripheries to improve centration, but that really doesn't help us address internal astigmatism, residual astigmatism, perhaps. And I know there are designs out there not with FDA approval that have toric base curves,
right,
and are able to do that. So I'd like to see some research here and submission to FDA to do that, because I think that's the first step. Then going into perhaps hyperopic treatments or presbyopic treatments. And I know they exist out there, but I want to just say fairly clearly, I'm pretty adamant about treating, especially kids, only with FDA approved designs and materials. The bottom line is, as you know very well, any contact lens, even daily disposables, there are going to be ulcers.
Yeah.
It just statistically is going to happen. It's rare, but it's going to happen. And it's going to happen in cases of Ortho-K, even in the best fitting environments. And if a kid suffers an ulcer, if it happens to be central, if they happen to get scarred down, if they lose vision, well, you're probably going to get sued. Even if it wasn't your fault, you didn't do anything wrong. And if you did not use FDA approved materials, FDA approved designs, I think your position in defending yourself, even with informed consent, is much more tenuous. So it's just not worth it to us in our practice. I don't need to do those things. There's plenty within the realm of FDA approval that we can work with. That's just my personal feeling.
That's an interesting take. As well as when you were listing the other things that you'd like to see, again, this is mimicking the refractive surgery arena as they continued to make changes through instrumentation for their techniques to be able to accomplish those same types of things. So I think we're going to close now. I always tell you this, it's a pleasure to get the chance to chat with you. And I learn as much as anybody, from your vast knowledge in this field. I think you've taught us a lot tonight about the designs, when to choose a toric, when to think about a sphere, the lens materials in this balance of properties and it's a high DK. And then these tips at the end about the patient management, I think are really, really right spot on, because that's what ultimately will make the patient successful. So I'd like to thank our viewers that are listening this evening. I'd like to thank once again Euclid Systems for sponsoring this event. There will be another one in a month, and hope that everybody tunes in. And Barry, my colleague, my friend, thank you so much for being a part of this evening.
Thank you, Craig. It is always a blast to talk with you, always.
Thank you.
Have a good evening.
Thanks, everybody. Good night.
Bye.
Bye.